morning.
Yeah. No, the same thing.
All right, so we go live in
Okay.
1 minute, everybody. Request everyone to mute the microphones. Thanks.
So I just actually for video I have given voiceover. Should I continue with the same?
Yeah,
Or should I talk?
not a problem. Only when you share the video, include to share sound when you when you share your screen.
Okay.
Yeah, and if I'm not getting the sound, I'll let you know. You can start speaking. Not a
Okay.
problem.
Okay. Thank you.
Good evening, everyone. Welcome to today's session brought to you by IASO Academics. Today is Mastery of Surgery. We are 16th webinar in this series, and the topic for today will be neoplasms of the stomach. I invite IASO President Dr. T. Subrameshwar Rao to kindly open the session for today.
Good evening, everyone. It's a privilege to be the president of IASO, and it's truly an honor to be introducing these three gentlemen. Sumicha represents the energy and the talent that is spread across the country among surgical oncologists, a real hope for the future cancer patients in this country. He's a consultant surgical oncologist, robotic and advanced laparoscopic surgeon. He works from his own place, Pro-Life Cancer Center and Research Institute in Pune. He would be giving us a video tutorial of D2 gastrectomy, the resection part of it. Welcome, Sumit. Sujit Chai Patnaik is somebody who's brewed and bottled in our institute. Brilliant surgeon, known for his endurance, energy, and enthusiasm, and training, teaching and training skills, and patience. Somebody who's a great asset for the institute, and he would be talking to us on reconstruction following gastrectomy. And the third and the most colorful is Mohammed Adam, a brilliant surgeon, wonderful human being, great friend. Always good to see him while we are in US and when he visits India. He's an associate professor of surgery, director of robotic HPV surgery, and he has a special interest in peritoneal surface malignancies. He's also a member of NCCN colon, rectum, and small bowel guidelines, not a small achievement. And he's the leader and founder of UCSF Artificial Intelligence Research Group in Surgical Oncology. He's also a co-director of minimally invasive liver surgery masterclass, which is run annually. He's affiliated to the University of California in San Francisco. He will be talking to us about robotic-assisted endoluminal resections of gastric tumors. That's not done by most surgeons across the world. Welcome, Mohammed Adam, and thank you very much. IASO is grateful to you for sparing your time for the students and the faculty of IASO. Thank you very much.
With that, we'll begin the webinar for today. We invite our first speaker, Dr. Sumit Shah. You may share your screen. He'll be speaking to us on minimal invasive subtotal and total gastric resection. So gastrectomy with D2 lymph node resection. He'll be covering the resection part. Over to you, Dr. Sumit.
Yes, thank you. Thank you, Sridhar. Now, I will start with, first of all, we all know the lymph node stations. Station 1 to 12 are the main lymph node station for D2 resection, and then up to 16s are D3 lymph node resection. Majority of D2 are up to station 12. Sometimes we go out of the boundaries of the lymph node dissection. Here, for subtotal gastrectomy, we all know that station 1 to 7 are important, and then D2, we need to add station 8A, 9, 11P, sometimes 12A, and adjacent, we immediately go to 12P. And in total gastrectomy, we go for all station 10 to 12A, 12P. So first video is about starting laparoscopic subtotal gastrectomy with D2 lymph node. Subtotal gastrectomy specifically, we have to clear along with station 1 to 7, 8A, 9, and 12A. So this is the OR setup, surgeon standing, and these are typical ports for laparoscopy, all 5 ports in all upper abdominal surgery. Surgeons stand between the 2 legs of the patient. So ergonomically, it is very easy to perform upper abdominal surgery standing between the 2 legs. And ports are also placed laterally. So here, actually, we start all the surgeries from dividing greater momentum. But in this case, as the colon was attached to the gallbladder, surgery started from level 5. So here we can see the traction is given on the duodenum, pancreas is exposed, and dissection is started. This is actually a case post chemotherapy case. There was good response at primary, but nodes are not responded well. We can see all enlarged lymph node. Now, this is station 8A lymph node, that is anterior group of lymph node along the hepatic artery. So, how we handle the lymph node is very crucial. We should not break the lymph node, just hold the fascia covering over the lymph node and dissect. All these lymph nodes have blood supply directly from the branches of hepatic artery or vasa vasorum, which are supplying to the hepatic artery itself. So instead have a good grip over the lymph node instead of tentative grips on the lymph node, or don't abolish lymph node partial. Now dissection proceeds further. Bipolar and harmonic are very good instruments. We can use bipolar for minor bleeds vessels and keep on dissecting. Now, as we proceed dissection along the hepatic artery, from common hepatic artery, we proceed to the hepatic artery proper. That is, first we will see the left branch of hepatic artery, and then all the plane in hepatoduodenal ligaments is dissected. As the growth is in the pyloric antrum, so clearance of hepatoduodenal ligament is crucial in this. Though standard T2 involve only 12A lymph node, we are clearing 12A, 12B, and 12D. That is anterior, posterior, and along the duct lymph node. So this is 12A lymph node along the hepatic artery proper. Those are going to be clear. Just keep all the vascular structure under constant vision, and dissection, like open surgery, how we dissect, same way we dissect and divide. Only thing, a good camera person and close-up view is very crucial in laparoscopy while doing this lymph node dissection. Here we can see the hepatic artery, common hepatic artery going into the making as the hepatic artery proper. Now we proceed dissection for the lymph node station 12B. That is, now we will see the portal vein and dissect all the lymph nodes which are along the portal vein. All these lymph nodes, we all know, go as a lymph node chain posterior to the portal vein. All these posterior lymph nodes need not to be cleared. They are mainly draining lymphatics of the gallbladder, CBD, and pancreas. Once we clear all these lymph nodes, attention is shifted towards the celiac axis. Here we can appreciate hepatic artery and portal vein. Now, this is a major vascular injury. Here you can see the left gastric vein is stretched and avulsed. This is the wrong method of handling the left gastric vein. You should clip it properly, identify it. There are various types of left gastric vein depending on their position. We will see in a short time. Remaining lymph node at the hepatoduodenal ligament is cleared. That is lymph node or fibrofatty lymphatic tissue along the duct. Now, here we can see celiac axis is exposed. splenic vein we can see covered with the lymph node tissue. Then all the lymph nodes along with the celiac axis and left gastric push towards the specimen side. This is the left gastric artery. These lymph nodes along the left gastric artery are station 7. We are clearing these lymph nodes. In D2 gastrectomy for distal lesion, we need not to clear station 11D, that is distal splenic aortic lymph node, and station 10. Here we can see all the lymph nodes along the celiac axis, splenic vein are clear. Now we are shifting our attention towards the station 6. As generally this is the first step in all the but in this case, as colon was attached initially to the gallbladder, we did that step first. So anyhow, it is a clockwise manner. Either you start from level 6 or level 5 and then come down. Now, care is taken while handling gastroepiploic vessels because they are very thin and even little traction causes bleeding at the gastrocolic trunk of finger. We can appreciate here we are clearing all the lymph nodes along the vein. And duodenal wall. Here is the artery and vein exposed. All named vascular structure, we should clip or line it. We always use hemolock clip. We generally don't prefer simple lega clips to clip the vessel. Here we can see artery and vein is clipped and all the lymph nodes are shifted towards the specimens. Once this step is completed, duodenum is transected. Already we have divided greater momentum probably. This is little bit remaining lymphatic and fibrofatty tissue along the laser curvature we are clearing. Line of transaction in subtotal gastrectomy, almost 3/4 stomach should be removed. Specifically when gastric outlet obstruction is there, keeping redundant stomach causes gastroparesis. Here we can see the proximal division of stomach. Blood supply of the gastric conduit in this situation is from the short gastric and sometimes from left gastroepiploic vessels. So here we are checking all the hemostasis. The distalmost portion of splenic artery is not clear. That is station 11D, we did not to clear in subtotal gastrectomy. Specimen is retrieved in endometrium. Thank you. Robotic total gastrectomy with D2 lymph node dissection. This is a post-neoadjuvant chemotherapy patient. 4 cycles of clot were received. There was good response to the primary, but nodes were not responding. Now, standard ports are placed. Here we are hitching the lever with suture and it came out of the field. Now the standard steps as dissection start along the greater momentum and then we reach to the station 6 lymph node. First clearance of station 6, here we can see the middle colic vein going down and now we are going towards the right gastroesophageal vessels. These are very fragile veins and draining into the gastrocolic trunk of Henle and gastrocolic trunk itself drain into the ESMA. So care is taken while handling. Even if we use vessel sealer, it is my preference to clip all the named vessels. Here we are dissecting artery and vein separately. I am clipping again, even it was divided with the vessel sealer. These station 6 lymph node are taken, sent separately. Then dissection is done to mobilize length of duodenum for stapler preparation also. Once this is done, gauze is kept at the side and station 5 lymphatics and tissue are clear. The gauze act as a landmark for separation of the planes. Once this is done, duodenum is transected with sure-form stapler. Now, focus is shifted to the station 8A, that is common hepatic artery lymph node, anterior group. We can see all the lymph node tissue along the hepatic artery. The open facial planes in hepatoduodenal ligaments are started dissecting. Station 5 lymph nodes are cleared. Here, trick is to hold the fascia over the node and not to over the node because the nodes bleeds because the blood supply to the nodes is directly from the hepatic artery or major vascular structures. After clearing the node, same lymphatic chain is clear. Here you can see 12P cleared, portal vein visualized posteriorly. This patient had very good response in the primary stomach, but all the lymph node stations were enlarged. So we have to clear all the lymph node stations. Now 12A lymph node station is clear. The benefit of robotic we can appreciate here, camera control in surgeon's hand. So surgeon's autonomy is very useful. Stability of robotic platform and three-dimensional vision gives additional benefit to the surgeon. Now here you can see left gastric vein, the various types of left gastric vein. We have to identify and clip it properly. Once left gastric vein is clear, then attention is shifted to celiac axis group of lymph node, that is station 9. The same chain continues as an 8P that are also dissected. Now here we can see the assistant is putting suction on the hepatic artery. The adjustment, traction on the pancreas is readjusted with the gauze. This is partially teared node. We can see it is bleeding. And that takes additional efforts and time. Instead of that, we should hold node properly. But the end result should be all the lymph nodes at each and every station should be cleared completely. Here we can see completely clear station 8P. Now we are shifting towards the left gastric lymph node. Already we have cleared celiac axis group of lymph node. Now this left gastric, that is station 7 lymph node, we are clearing. Left gastric artery is doubly clipped and divided. Keeping the cigar gauze on the pancreas as a traction is very useful maneuver to retract the pancreas. Once left gastric is divided, the same dissection continues along the splenic artery. Proximal and distal, that is 11P and 11D lymphatic lymph node groups we need to clear. Here you can appreciate the proximal lymph node group are clear. Now we can see hepatic artery, splenic artery, and aorta. Left gastric is originating separately and not as a celiac axis. This is station 11D, proximal distal part of the splenic artery is cleared. The remaining clearance will be done again. We can see later part of the video. Now, station 1 along the right crus of diaphragm and cardiac group of lymph node are clear. Then hiatus is open and left cardiac group of lymph node are also clear. Here remaining part of lymph node along the pancreatic border and splenic artery are shifted towards the specimen side. Esophagus is lifted up. All the remaining attachment of the fundus and the lymphatic tissue should be taken towards the specimen side. Now, anterior and posterior, right and left vagus, as we call, are divided to gain the length because the lesion was in the gastroesophageal junction. Now this is left vagus we are dividing. Once we clear all this part, we will have better view whether we need to clear lymph node at the splenic height. Now, all the greater curvature, not necessarily we need to do omentectomy. Here we can appreciate this is the left gastroepiploic artery arising from splenic artery and we are dividing. Entire stomach is pulled down. Specimen is mobilized. Stitch is taken upper border of esophagus and the line of probable transaction with the idea to avoid retraction of esophagus. This is completed anastomosis. This is Oringer technique of anastomosis, side to side anastomosis. The specimen is retrieved at the end. We can see the completed anastomosis. Thank you.
Thank you so much, Dr. Sumit. We'll come back to you after our 3 presentations for the Q&A. We move on to the next presentation now. That's by Dr. Sujit Patnaik, and he'll be speaking on reconstruction options after the types of gastrectomy that Dr. Sumit has shown. Over to you, Dr. Patnaik.
Good to go. Sorry.
Yeah, we are good to go. Please go ahead.
Good evening, everybody. I am Dr. Patnaik. Greetings from Baswatarakam Indo-American Cancer Hospital, Hyderabad. At the outset, would like to thank the IASO academic cell for giving me this opportunity to present in this forum. And the topic for this evening is reconstruction option after gastrectomy. We have already seen Dr. Sumit's nice resection and very good D2 lymphadenectomy, both in the minimal invasive surgery, both in laparoscopy and robotics. So for restoring the gastric continuity after the resection, the reconstruction of the gastric tract need to be done. Though there are several reconstruction techniques available from time immemorial, that we have all practiced, but the best reconstruction is the one which maintains a physiological optimal status and gives a good quality of life and has a low post-operative morbidity for the procedure done. I will be getting into a few basics as because most of our residents and the postgraduates have also logged in, and discussing on the principle and the choice of reconstruction. The principles are based on the technicality of the reconstruction also. Technically, how it is feasible to do that, to choose that particular reconstruction, and that should not result in big morbidity, because as the cancer patients, they are already run down nutritionally, and the functional outcome and the physiological outcome should be adequate for maintaining a good quality of life. In that way, no reconstruction option is ideal, but we need to choose and tailor-made the reconstruction procedure according to the patient's requirement. While choosing, there are a few main things we need to keep in mind, like the likelihood of a recurrence. All of us know once for a gastrojejunostomy, when we plan, we try to take the jejunum above the colon so that in future, if there is any bed recurrence infiltrating or the nodal recurrence infiltrating the transverse colon, that area, it may jeopardize the gastrojejunostomy conduit. And so as the body habitus also. Few patients have a typical body habitus where the degree of freedom for the movement of the adjacent organs or the anastomosing limbs cannot be possible, like a short mesentery or a stunted mesentery may not be feasible for you to do anastomosis. So you need to have some backup plan for that. Today, from the options, we will be discussing in this pattern for distal gastrectomy, total gastrectomy, and proximal gastrectomy, which has its own methods of the conventional open method and the intracorporeal techniques, stapling devices and stapling techniques, semi-mechanical combination of the stapling and extracorporeal suturing. All this thing will be discussing in the further slides. A bit of patient preparation, as all of us try to operate the upper abdominal surgery mostly in the supine position with the French position, surgeon standing in between the legs, Allen stirrup or the yellowfin stirrup. The master cart and the slave monitors are placed as you see in your screen. The pneumoperitoneum is maintained at 12 to 14 mm, and which the resection part also is taken care in that. This is the OR setup and the patient position. We need to discuss something more on the port position and placement. So conventionally, when we started, as we know, the learning curve for all of us for the resection and reconstruction is always there. When we started evolving in this skill of minimal invasive, we used to do the procedure mostly from standing in between the leg with a supraumbilical optics and 2 midclavicular line and a left subcostal assisting port, and for liver retraction and utility port in the Ziphist epigastric area. But as we went through and started learning, and over a period of time, in the present day, we try to go through this 6-port technique always. So the cameraman moves in between the legs, and as because we have equally skilled surgeons, those who can, 2 surgeons can both from either side. So the operating surgeon and your assistant surgeon is as good as you also. So that makes the surgery easy and you save a lot of time in that. In the resection part also, excuse me, Dr. Sumit, from going overboard regarding this resection part, just to add a few points to it. When we operate mainly from the left side of the patient, there are certain lymph nodal stations which is generally adequately helping us because those are in line with the anatomy. So for us, our practice is in between the legs, will be addressing the station 6 and 5, transect the duodenum, lift up the stomach to the proximal side. Then the left-sided surgeon will clear the celiac axis 12-way clearance, and the right-sided surgeon can, if required, the proximal and the distal splenic clearance can be done from here. Similarly, this 6-port technique can also be used for your suturing, intracorporeal suturing. Most of the time when we started the esophageal anastomosis after a total gastrectomy, we used to address it from the left side. But after some time, we saw that for a right-hand person, starting doing the anastomosis from the right side is much more easier, because you have a good room and a working space for yourself. Otherwise, in some situation, because of the body habitus, the diaphragm on the left may abort your right-hand suturing techniques that I will be putting forth in the following slides. A general condition is that for the beginners, you need to have a well-perfused and the vascular proximal distal limb for anastomosis. It should be, as usual, the classical teaching, the end should be tension-free, and to secure all your angles, use a conal sutures. Adjust the nasogastric tube for decompression of the stomach in the postoperative period. And this is a hybrid Billroth 2 kind of a reconstruction. Hybrid in the sense the part will be stapled and the part will be, so the lesser curvature after transecting with adequate margin. The lesser curvature of the stomach is stapled with a triple row purple 60 millimeter stapler. So, and then you try to back the specimen gently and lift the transverse colon, find the DJ, choose your loop and hitch it to the anastomotic area. Make a small supraumbilical incision and try to retrieve the specimen from there. So that is. So the stay which you have held can be exteriorized and it will guide it to the wound through the wound protector. You can make the enterotomy there, prepare the jejunum, and now it's ready for a gastrojejunostomy open method. We use 3O PDS, all interrupted. Angles are Cornell's angle, center, free stitch, all interrupted sutures, equidistant. Perform the GJ and the jejunostomy. Complete it, and that's the final year. We add a feeding procedure also to it for most of our patients. It's up to you to choose. This is a lap intracorporeal gastrojejunostomy. Also the same thing, whatever you do in the open method, you can do it by minimal invasive also. So you can, instead of stapling, you can take a barbed sutures and try to suture the lesser curvature and do an interrupted things. Okay, so this is also through a continuous barbed suture also we can use. The previous one, what that video was in play was a interrupted PDS 30. Then we slowly migrated and started using the barbed suture, 20 barbed suture for the stomach closure of the lesser curvature, and anastomosis also for the GJ. So you close the lesser curvature of the stomach, find out the loop, and this is a loop gastrojejunostomy, or what we say the omega loop gastrojejunostomy. Most of us preferred a Roux-en-Y also. In the subsequent slide, we will see that. Angles, we try to always take a PDS 3O suture to secure it. And then we take a continuous 20 barbed suture for approximation of the posterior wall. take good bites under vision, approximating both the limbs from the jejunum and the remnant stomach. Bites should be equidistant and not to tighten. It may strangulate the anastomotic line. If at all you come across a shortening of the length of the suture, you can add one more suture from there. But most time, if you take a 30 centimeter long suture for a GJ, it is quite comfortable. Once you come to the other corner, you can try to invert the mucosa inside and start suturing. Here also we need to take a angle with 3O PDS to avoid any leak. That is our usual practice, what we do. And your barbed continuous suture starts along. In the meantime, you need to adjust the nasogastric tube also. Only thing is you need to be very patient and perseverant in doing this thing. Need not hurry up at all, because each bite is important for the patient and it should be taken with due care. And finally, the angle is closed. That completes the gastrojejunostomy. As I was mentioning, the Roux-en-Y gastrojejunostomy, which is favored by most of us, and typically the end of the proximal stomach stump or the esophagus is anastomosed to the jejunum. So the jejunum is divided at 15 centimeter from the Trees ligament, and either anticolic or retrocolic, to your comfort level you can take, and the JJ will be done at 40 to 50 centimeter, the classical teaching. So either can be mechanical or a manual anastomosis. So this is the open method where a Roux-en-Y gastrojejunostomy is done. You identify the Trees ligament, make a small rent in the mesentery, take a 55 millimeter stapler triple row, try to prepare the Roux loop with adequate length, and measure the anastomosing limb. That scale is around 15 centimeter in length. So around 45 to 50 centimeter, a bit more than 50 centimeter, your jejunostomy will come, and you start doing the open method of gastrojejunostomy. We need not go into the details. This is the repetition of the first procedure. So once it is completed, this looks like this way. This is the stapled and closed. This is the gastrojejunostomy and the jejunostomy. So laparoscopically also we can do a double stapling Roux-en-Y technique. The stomach resection and the loop identification will be done, and two methods of vertical and transverse stapling. This will be a functional end-to-end anastomosis. So excuse me for the repetition of the step, because for a procedure we need to mention the steps to continue with the video. So the resection is done there, and closure of the lesser curvature, as always, as we mentioned previously also, through the T20 barbed suture. That is completed the partial closure of the lesser curvature. Then you identify the loop with adequate length. See to it, it reaches freely to the anastomosing site. Then you can double staple by making the already pre-existing rent and the enterotomy here. That tacking suture, which will be there holding the both walls of the anastomosing surface, that will be useful in manipulating and mounting your stapler. The side-to-side vertical stapling has been done, and the transverse stapling will close the rent, and that forms the side-to-side function anastomosis, but it's a functional end-to-end. Reconstruction after proximal gastrectomy is done. We only practice this for early cancer involving the upper third of the stomach, but it's the best thing to preserve the physiological function of the remnant stomach. And here we will be, though many options are there, but mostly we will be discussing on the double track reconstruction. The double track reconstruction is the best reconstruction procedure in respect to the reflux esophagitis. The conventional Roux-en-Y esophagovaginal anastomosis is similar to what we will be doing in the total gastrectomy, and the side-to-side gastrojejunostomy will be performed at the 10 to 15 centimeter below the esophagovaginal anastomosis. So this is the open method, that the transection of the stomach and the remnant stomach tube. You find out the ligament trees, prepare the bowel, and prepare the Roux loop for that. Take care of the mesenteric resection, stapling with a 55 millimeters triple row stapler. The same conventional open method of doing a esophagojejunostomy. Here we are taking 3-0 interrupted all free sutures, and that completes the esophagojejunostomy there. And then the remnant stomach and enterotomy on the jejunum is made to complete the gastrojejunostomy, and this is the completed anastomosis. The JJ, whatever you have marked with the scale, which is around 50 to 60 centimeter, will be anastomos here. So you see 3 lines of anastomosis: esophagojejunum anastomosis, GJ and JJ. That completes the double track. The same thing we have done intracorporally also. Roux loop is prepared, adequate length of 45 to 50 centimeter mark, enterotomy is done, and the angles are taken on the left side, and you complete the esophagojejunostomy with the 3-0 15 centimeter barbed suture. Mainly we use the V-lock from the posterior wall and anterior too. Take good bites under vision. Try to invert the mucosa inside. On the esophagus side, you need to be careful. And mostly we do this from standing on the right side of the patient. As I told you, the movement of your hand is better there. And the gastrojejunostomy is also performed with same. This is a 2-0 barbed suture, completing the posterior wall, and now the anterior wall is about to get completed. And when we try to extrude the specimen or retrieve the specimen through a small incision supraumbilically, you can perform the jejunostomy through that. and if required, whatever according to your choice, you can either a nasovaginal or a feeding jejunostomy can be done. Reconstruction after total gastrectomy. Lot of techniques have been described about this, but here today we will be discussing mainly on the stapling pie type of anastomosis, which is a functional end-to-end, but a side-to-side anastomosis, and intracorporeal esophago-jejunal anastomosis. For a total gastrectomy, initially when we started doing for esophago-jejunal anastomosis, we started hitching the both ends of the remnant esophagus to the anterior abdominal wall. So that stabilizes one of your anastomosing surface, and enterotomy, the jejunum is made, and we started working from the left side of the patient. You can see my working port or the right hand is coming from the left side subcostal port. Sometimes it may have some issue if you have a deep subcostal margin where your diaphragm or the ribs may hit your working hand on the right side, you being a right-handed person. So you may not be very comfortable doing the anastomosis. So better to shift your side to the right and start continuing from left to right. So this is a continuous again 3-0 barb suture. From right to left we have done. And the anterior wall you need to take one more suture. Pass the NG tube distally and close the remnant esophagus. Here you need to be careful to invert the mucosa so that it is quite clean and the healing is fine. Never to compromise with the basic principles of anastomosis. Once that is done, we always hitch the jejunal limb to the crus of the diaphragm so that to reduce the tension on the anastomosis, and place the cut falciform ligament over the anastomosis as a patch, as extra prevention. The same thing, another method is that at above, just above the G junction, the esophagus is cut. This video will depict working from the right side of the patient. Once we matured over our suturing skills over a period of time, then those days from 2, we have come to 1, because once one end of the esophagus is stabilized and you have developed the skill of suturing, you can manage with one stay, preparing the rule loop, measuring the limb length, and with 3-0 barb suture 15 centimeter, the suturing starts from the left to right, surgeon standing on the right side. Here you see the movement of your needle and the ease or the comfort of doing the anastomosis is optimum. And most of us now prefer doing this anastomosis standing on the right side. See to it the ends are approximated well. And good chunk of jejunum and esophagus is taken. So once you come to the left, you can cut up the stay, adjust the nasogastric tube, and close the rest of the thread. So that completes, and as I told, we hitch the anastomosis into the right crus, and that completes the anastomosis. This is the esophagovaginal anastomosis after total gastrectomy, which is a functional end-to-end anastomosis or called a pie anastomosis. The limbs identified with adequate length taken to the esophageal side, preparing the rulu. Make a enterotomy to negotiate the staple. Take a stay suture from the posterior wall of the jejunum to the stomach. That will be your guiding suture or manipulating suture. So once both the ends of stomach and jejunum is approximated, try to maneuver and negotiate the stapler, 60 millimeter blue or purple, whatever to your preference. So side to side anastomosis of esophagus and jejunum is done. Now prepare the mesentery for the transverse stapling. You may require 2 staplers over here because of the bulkiness of the mesentery and the anastomotic area. So once the second stapler is fired, your anastomosis will be completed and the specimen gets liberated from it. That completes the pie anastomosis of side to side, functional end to end. So my take home message is no specific method is better over the other. So you need to have the knowledge over all the merits and demerits of anastomosis area. Strict adherence to the general principles of anastomosis should be done, and you should be aware of the post-gastrectomy complication and due prophylactic measures should be taken. Thank you.
Thank you, Dr. Patnaik. We move on to the third topic for the day, and that will be robot-assisted endoluminal resections. And the speaker is Dr. Mohammed Adam from UCSF. Over to you, Dr. Adam.
Can you hear me?
Yeah.
Yes, all good.
Thank you so much, Dr. Shukla and Dr. Rao, for the kind invitation and the generous introduction. It's an honor to be with you and here and to be part of this esteemed panel. I've learned a lot just from watching Dr. Patnaik and Dr. Shah, so this is super helpful. And I am no stranger to Indian hospitality. I was hosted at the IASO meeting in 2023 in Mumbai, and following that, I went to Hyderabad and was kindly hosted by Dr. Rao at the Indo-American Cancer Center. And from that trip, I've struck, many friendship, mentorship, collaboration. I've learned a lot about doing radical gastrectomy from Dr. Patnaik, Dr. Rao, and Dr. Shukla, observing how skillful they are. So this is much appreciated. And Dr. Rao, this is the necktie that you gifted me, so I'm still wearing it. So just wanted to thank you for that. The outline of this talk is we're going to talk about the clinical need and rationale for doing this endoluminal approach. And, we'll highlight 2 cases. I will pull the audience on what they would do next. We'll talk about the setup and some videos, of course, and ideal indication and hint at the future. So the case number 1 is a 47-year-old IT tech and in the Bay Area here in San Francisco, otherwise healthy, presented with a symptomatic large mass at the GE junction measuring 8.5 centimeter, presented with difficulty swallowing, causing some fullness and early satiety. EUS FNA showed a large leiomyoma at the GE junction. This is the CT scan. You can appreciate the size of the mass and the depth of it and the involvement of the GE junction. So question number one is if you could, stick out your phone and scan the QR code and let me know, would you do a total gastrectomy, yes or no? I'll give it about 20 seconds. Hopefully the internet connection here would be okay. Oh, that's a split. Still moving. I will close it at 10 responses. So the vast majority of folks said no to total gastrectomy, but then what kind of gastrectomy resection would you do? The patient is symptomatic, and if you could just humor me, and for this is the last time that we're going to pull the audience, and let me know what kind of gastrectomy would you do? Would you do a total? Would you do a proximal gastrectomy? Would you do laparoscopic resection via the front door? The serosal resection? Would you do laparoscopic endoluminal resection? And we'll cap it 2 more responses, and we'll cap it at 10. All right, awesome. So I think, the vast majority recommended proximal gastrectomy for this. And I think 37% recommended the laparoscopic endoluminal resection. So we've got 12, I think, still proximal gastrectomy. So I'm going to go through the options here. I think, total gastrectomy or proximal gastrectomy is the most traditional and the most straightforward. However, there are quality of life changes and nutritional changes, especially like if the patient is young and so on, a long-term stricture rate. Endoscopic inoculation or resection is hard. You can see the mass at the GE junction. This is an intraoperative EGD. And the depth of the mass is also of a concern. So imagine that you're resecting in retroflex and you're trying to repair things in retroflex. Laparoscopic resection via the front door with serosal gastrotomy or gastroesophagectomy. And I think, it's a straightforward of these gastric preservation technique. It's easier to sew because you're sewing from front to back. And then, however, there's a risk of injuring the vagus nerve and potentially some stricture concern. The laparoscopic endoluminal resection is very appealing. However, it's technically difficult. Honestly, I can't do it personally. The reconstruction is a little bit of a challenge because you're working in a deep area right at the GE junction. And then the question is if the laparoscopy is the right platform for this procedure. So I would say there are only a handful of exceptional surgeons who would be able to do this laparoscopically. Certainly, I'm not one of them. I won't be able to do it. This would limit the generalizability of the procedure. So there are very few people who would be able to do it. And a bigger question is that, do we have a good platform for this? And I think, you could argue that laparoscopy is more versatile. The robot platform is more versatile because of the articulation and the optics that comes with it. So is it a good platform to do this endoluminal resection? And I think, the concern is that is not approved for endoluminal resection. This is the multi-port XI. It will have to be going through the stomach transgastrically. There's risk of contamination. Figuring the setup out is also a concern. When I talked to the patient, then we talked about the versatility of the robotic platform in terms of the resection, reconstruction, you're working antegrade, you're dissecting antegrade, you're sewing antegrade. There are potential benefit that comes with this, that minimizing the risk of total gastrectomy or proximal gastrectomy. In a setting of a benign tumor, right? And this patient are expected to live a long life, and their quality of life benefit that comes with preserving the stomach in a 46-year-old who's expected to live at least 30, 40, 50 years. This is the setup. The room that I work in now, it's a bigger room where I use the endoscope as well as a robot at the same time. Patient is in reverse T-berg, tilted to the right side to make sure the stomach drop down and below the rib cage, arms out. I use endoscope for two things: initial visualization, insufflation, and a third, three things, a bougie to make sure that we're not constricting the or narrowing the GE junction. Use the Da Vinci Xi for this double docking. So transabdominal ports, you go in through the stomach, and then transgastric port into the stomach with the robot, and with air docking. So we put a balloon port, and you will see the video, into the stomach transgastrically to cinch the stomach up, and then you air dock the robot onto it. These are the steps: intra-abdominal docking, as mentioned, intragastric docking, dissection of the mass and the resection, defect repair, specimen extraction, and gastrotomy port closure. These are the ports highlighting the transabdominal port at the umbilicus, and the gastric ports are under the rib cage, left rib cage. This is kind of, it started with endoscope to insufflate the stomach and kind of get an idea of where you want to place a port throughout the skin. And traction sutures are helpful. This is case number 1. A little bit of tentativeness. You go along the greater curvature of the stomach. You put in balloon ports into the stomach. And a little bit of struggle here. This is case number 1. You blow up the balloon, and you place the suture transfascially and pull it up to cinch up the stomach and deflate the abdomen. This is after docking into the robot. You could see that this is inside the stomach. You could appreciate the size of this leiomyoma. This is the endoscope from coming from above. This is driven by the surgeon, not the gastroenterologist. Having that skill is helpful. And then scoring the mass, dissecting it off the serosa. You could see that this is the serosa, maybe a little bit of layer of muscle, but the mass is completely inoculated from that area, proceeding to the GE junction. These are the attachment to the GE junction area. And combining the robotic scissors and monopolar hook cautery is helpful. I think the sealer wouldn't work really well because it's too big and large. And then the mass is completely disconnected. You could see the EGD there. Then the defect is repaired. And the GE junction defect, I repair it, interrupted sutures to minimize the chance of narrowing the anastomosis. And then for the distal defect in the stomach, repair that muscular defect using a 3/0 V-lock suture. The space here is so limited, therefore the V-lock is really helpful because you're going to be tying these or suturing almost with one hand. It's much more difficult for the GE junction defect. I left this unedited just to highlight the difficulty, and you got to take your time. Then the mass is placed in a bag inside the stomach. And for the first case, we extracted it. We just enlarged the gastrotomy, the port sites, 2 of them, connected them together, about 5 centimeter gastrotomy. Remove the bag through that, and then place another bag to remove the specimen through a fan and seal incision to minimize contamination. Then closing the defect, we are really at the a greater curvature. We don't want to disrupt the vascularity of the stomach nor cause bleeding. So I think, suturing that is probably better. And this is just, regular suturing. You could argue to do just a single layer and then tack some momentum over it. Obviously, this is the first case you want to make sure is done, the patient does really well. And this is a patient did a phalangeal. You can blame me or the resident for doing this, crooked phalangeal extraction side, but you could see that the transgastric and transabdominal port side here. Uncomplicated course, no complication, discharge home on day 4 on full liquids. 1 week after, he was advanced to pureed and full liquid diet, a regular diet. After that, the pathology showed leiomyoma, no cancer. 1 year follow-up, patient is doing well. For some reason, he got a repeat EGD, EUS, showed no recurrence and doing really, really well, and all of his symptoms resolved. We were able to present this at SAGES and also publish this. This is the QR code. If you would like to look at the paper for the setup and more details about the conduct of the operation. Separate to this, we have developed a technique where we extract non-adenocarcinoma specimen or tumors in the stomach through the mouth. So basically, a patient would come in with a GIST or any benign pathology in the stomach. So we resect it and then extract it through the mouth. The patient would go home the next day because literally they would have the largest incision would be an 8mm incision, and this is recently published here. So, so the question is that, can we forgo the phalangeal? Can we forgo the a larger gastrotomy to minimize contamination and do endoluminal resection and then extract it through the mouth? So basically supercharging that with the idea that you can increase the minimally invasive nature of the operation. You enhance post-op recovery and decrease contamination burden from a larger gastrotomy incision. We presented this case at SRS in 2024. So endoluminal resection robotically and transoral extraction. This is another case. This is the case that I'll be presenting. Is a 46-year-old. The second case with abdominal pain. She had this large GE junction, about 9 centimeter mass, confirmed to be leiomyoma on EUS biopsy. Steps are the same. The addition here is adding the transoral extraction a step here. And this is the intraoperative EGD done by the surgeon. Then we moved on to the intra-abdominal docking first. So the balloon ports were placed. And then I switched to PDS, sutures, easier to handle, put in the balloon ports, and then deflate the stomach, the abdomen, and then, dock intragastrically. You can see a little bit more comfort, a little bit more flexibility here, and decisiveness with using the platform to address this. The case was much faster, dissecting it using monopolar scissors and hook cautery. And these are kind of the last attachments. Then came the transoral specimen extraction. Basically, we put in an endocatch bag into the stomach, and and then extracting it and snare it out through the endoscope. This is the endocatch bag. You cut it, put a snare in, and all of this done by the surgeon. Obviously, it's not that difficult. And then the specimen disappears. Then repairing the defect. You could see a little bit more comfort again, and after gaining more experience, to be able to suture here in this tight area. Basically, you're suturing with one hand because the other hand is retracting the stomach with tenting on the scope, so you can get a little bit more space very proximally. It's very hard to see. The scope also is used for insufflation based on the stomach shape. So if you use supports for insufflation, it wouldn't give you good visibility of the GE junction. You could see that appreciate the gastrotomy are very small here. Not a giant one. And again, just tacking it for good luck with the momentum. And then closing the port. Intraoperative leak test was negative. Postoperative course had uncomplicated course. This is the site. This is the specimen that we removed. It's intact, not fractured. And this is the actual patient picture post-op. You could see the ports, the transgastric and the intra-abdominal. Added a 5 centimeter system port just for suctioning, once we get into the abdomen first. Patient discharged on day 4 on full liquid diet, advanced to regular diet. After that, there was no need for narcotics since day 2 or 3. It's only Tylenol or acetaminophen. And there were no complication at follow-up, 3-month follow-up. We're able to publish this at Annal Surgical Oncology. Feel free to scan the QRS code to watch the video there and get a little bit of more info about it if you are interested. So the advantages of combining the two approaches, you preserve the GE junction, you minimize the risk of vagus nerve injury, and then facilitate recovery with minimizing the need for narcotics, which is a big problem here in the United States. Some technical tips: that traction sutures on the greater curvature is very important, help you with making the gastrotomy, placing the ports and tacking the stomach to the abdominal wall transfascially. The balloon ports are helpful to create a seal. Use at least 12 ports, to assist with that. The 12 ports will allow you to air dock the robotic port into the stomach. And this is kind of a trick of fooling the robot that you really dock in the abdominal through the abdominal wall. Endoscope is helpful in maintaining insufflation, as a regular port insufflation wouldn't show you the GE junction really well given the shape of the stomach. And use CO2 for insufflation, obviously, otherwise you might end up with a bad alias. Conclusions: it's technically feasible. This endoluminal robotic approach resection of these gastric tumors. While the setup is extensive, it's ideal for GE junction non-adenocarcinoma tumors. As alternative is extensive, whether it is a proximal gastrectomy or a total gastrectomy for such a benign diagnosis where a patient is expected to live a long life. There's also minimizing the chance of vagus injury, and the GE junction leiomyoma, the poster child for this approach. Obviously, it could be used for other non-adenocarcinoma diagnosis. Caution with GIST, I would be careful unless it's completely endoluminal or endophytic. Endoscopic skills is key. This approach can be supercharged by combining it with transoral extraction. It's not for malignant tumors. Future, I think, this is kind of just a landscape of the many robotic companies in the market, over 50 of them that are making some sort of a surgical robot. I think, we're going to have an endoluminal robot soon. I think this procedure will definitely be done endoluminally and robotically. And our gastroenterologist colleagues might be doing this if we don't pay attention and take over that practice. If you are in the Bay Area in San Francisco, feel free to reach out. Happy to host you. These are some of the people that stopped by and visited us. If the time is right, we can also arrange for some robotic drills or practice for these different anastomosis. And it's been great, like working with the resident doing that. So I found it to be super helpful. This is one of the HJ anastomosis done by a chief resident at PGY5 here. So it's really good. Happy to collaborate in that regard. Want to give a shout out to our team. It takes a village. This is the UCSF celebration of 15,000 cases. I happened to do that number 15,000 cases. I did not do 15,000 cases, but I did a duodenal resection with that, and they were celebrating it, so I enjoyed the moment there. Again, thank you so much for the time. It's an honor to be here. I've learned a lot from this forum here and continue to learn, collaborate from you guys. And thank you, Dr. Shukla and Dr. Rao, for the invitation. Let me know if you have any question. This is my contact info. You can scan the QR code and let me know.
Thank you so much, Dr. Adam. So great presentations by all our faculty, and we move on to the final part of this webinar, which would be Q&A. Before I go ahead with our routine questions that we have in Mastery, I think I have a few open questions on the Q&A. And what I'll do first is address these questions to our faculty. So the first question is, I think, to Dr. Sumit, which was, and I invite Dr. Patnaik and Dr. Adam with their views on these topics as well. Do we need to remove 12P and the 12D in D2, or is that only for that video where you had enlarged nodes? Or do you do them by routine? Dr. Sumit.
Yes, we don't do routine by definition. We don't need to remove 12P and 12D in distal or subtotal gastrectomy. But as it is a chain of lymph node, you see it 8A enlarged, 8P enlarged, and then it goes as a 12P. So we have to take out these lymph.
So only as per need.
Yes.
I don't think any differing views from the other faculty here. I think the next question, I'll post it to Dr. Patnaik here. For a para-aortic node, which is post-chemotherapy, so I think the participant wants to ask that if there was a para-aortic node to begin with, and you've chosen this patient for a curative intent multimodal therapy, and you're trying to address it, which approach would you choose for this lymph node, Dr. Patnaik, and perhaps Dr. Adam after that?
Para-aortic node for clearance or for reconstruction, or what?
No. For resecting a para-aortic node.
Resecting a para-aortic node. Do we
Correct.
really need to address that?
Correct. So I think we'll have to qualify this question better by which para-aortic station it is, 16,
yes.
A1, A2, B1, B2, all those things.
Yes.
Yeah. Dr. Adam, would you be addressing such nodes in any of your stomach cancer surgeries?
Yeah, I think, it would depend on the location, but also on the biology of the disease. So I think if we think this is more of a metastatic cancer or a stage 4, then I think the approach should be different. I would be very cautious going for it. Maybe preoperative systemic therapy, multidisciplinary discussion, and then if it's limited, one area, easy to get, and then we are sure about the biology, I think it would make sense to remove it.
Yeah. I think the third question is for the endoluminal surgery. So to you, Dr. Adam, wondering whether we can use gel port where we can dock all 3 ports in a single port.
Yeah, I think that's a great option. However, I think my bias is that the benefit of minimally invasive surgery is to split the incisions and to make them small. And you could do an appendectomy, or in like with a 1 to 2 centimeter incision, 1.5 centimeter, if you have the right patient, right? But if you split them into 5 millimeter port, 5 millimeter port, then the patient end up doing better because of that you're splitting and the wealth and the pain. I think I worry about a supraumbilical incision that's long. I think the risk of hernia is real with that. Also, the bigger the incision, there's some sort of contamination that happens. So I worry that might make it more likely to get infected. But it's a good thought. I think, as these endoluminal robots are developed, I think that might be one option. Because working anti-grade, it's good. Retroflexing it, even with the robotic port, might not be a feasible thing. But I guess you could do it. I think the issue is going to be creating a seal, the risk of infection and pain.
I think the next question is from me, Dr. Adam. I think the main driving message in this was for proximal G junction benign tumors where you would want to preserve the vagus nerve. Going endoluminally is a great option to preserve the function. And if one is not having the robotic platform and is working in a lower resource setting, it would still be a better idea, even if they are doing an open surgery, to do a gastrotomy, go endoluminally, resect it from inside, and just close the gastrotomy like you would do. And I think you would achieve at least the functional part of what you're trying to achieve.
Yeah, 100% I agree. I think, it's not about the technology or the technique. It's about what is available, how you can help that patient. So if you're able to achieve that through an open approach, and you're able to do it really well, I think, that's a great option. Even if you have the platform and you don't have the skills, I think you shouldn't be doing it because things could be made worse. Obviously, but I think, there are many ways of doing it. You got to think about your skill set, resources available, and you got to be honest with the patient. The first patient, I told him, you're going to be patient number one, but it was like, I'm willing to take that risk because I'm 46 and I've got like many, many years, and I considered him for both. I said, well, downside to this, we'll do a total gastrectomy. Obviously, we don't do proximal here in the US, but that kind of was the conversation with them.
And I think the next question is, how do you prevent the pneumo, the CO2 going through the pylorus into the small bowel and just the intestines getting inflated in the abdomen?
Yeah, actually, that was a great question. I think I was super nervous about it. I think, if you look at the CO2 absorption, it does get absorbed really well. I think I have not noticed ileus in the sense of small bowel, that distension. I think the pylorus is really good, but even you're going to have some escape, but I haven't noticed it. One thing that I have noticed when you work in the GE junction, you can develop emphysema, which is fine. You just got to make sure you talk to your anesthesiologist and make sure they don't freak out. Because I think the second patient, they kept them intubated just because of concern of that, because they're not familiar with it. They don't do a lot of thoracic surgery in our main cancer center. We do it in the main hospital. So I think it's kind of a communication that you would have with the anesthesiologist. But I think the end titles follow that up, communicate with the anesthesiologist. But I think in terms of ileus, not a concern. You might develop emphysema, so you kind of Michelin man for a day or so,
Right. I think the next question in the Q&A is for Dr. Sumit, which is in distal gastric cancer. I think you can read the question as well. How far distally can we extend the resection to achieve a negative distal margin? Is there an anatomical landmark that defines the maximum distal limit before you start considering other organ resections?
The distal limit, we need a 2 centimeter margin. So by definition, gastric cancers are limited to the pylorus and opening. So first, you mobilize first part of duodenum. If sometimes you are in doubt, so many times I want to take pursing on the suture line. In that case, up to the ampulla, you can mobilize the duodenum, and then your transection line should be at least first part of duodenum. That much we can mobilize.
Right. Dr. Patnaik and Dr. Adam, any thoughts on this question?
Whenever we try to go distally to apply the transection line for the stapler, at least you need to ensure your gastroduodenal territory is free. And when you are trying to go with the transection, if that area is not free from tumor, then it is a very dicey thing to do and need to be a bit cautious, because anything beyond that, the patient will get into gastroepipals requirement. And for such an advanced disease, if for a afferent gastroepipals, that has to be taken with a pinch of salt, not to opt for resection then. So my take will be look for the GDA, because the GDA, when you are taking the posterior approach for your right gastric also, you need to chase the GDA also. And then reach the hepatic from where you can see your right gastric. So to clear up the posterior nodes also from there. So GDA, chasing the GDA will, I think, what we generally practice. And if it is not there, then we call it a day and make it unresectable. I think the similar thing Dr. Srajan encountered today while doing a case addressing the station 5 lymph node before this session. So actually we need to convert that MIS into open to tackle that, but fortunately we could clear that area and the resection was possible.
Dr. Dam.
Yeah, I 100% agree with that. I think, it has to be driven by the, if you're doing it straightforward, you're not worried about margin, I would be careful if you see the GDA, because if you go beyond that, then you might compromise the major papilla and / ampulla, and then you end up with a Whipple. So I think if you feel like you're too distal, then I would put a Fogarty catheter or so through the cystic duct. Make sure that if you stable it, then obviously you would want to know before you do that, but just to give you a little bit of assurance, I think, if you get too close and you worry about it, I think you're gonna have like a nerve-wracking 2 days until, like, looking at the belly and chasing it, and it's not a good feeling. So,
I think those are all the Q&As we have. I think we're short of time as well. What I'll do is we have a senior ISO leadership with us as well. We have Dr. Rudra Acharya, Dr. Sharad Desai, Dr. Subhaya Shanmugam. Any of them have any comments or questions for our faculty? We can take them.
Nothing. Congratulations, speakers and Sharif.
Good evening, sir.
Very good evening, sir.
Dr. Rudra, I think you were unmuted.
Yeah, I think it was a great show, especially the skills by Dr. Sumit, Dr. Patnaik, and Professor Adam. I think we have done laparoscopically the intragastric resections with balloon trocars, but I never thought that intragastric this robot can be docked and used. It's a great innovation. I think in India, I think none of us have tried. It's a great innovation, and I thank all the faculty for giving such a short, crispy, and lot of technical tips to the fraternity. Thank you very much.
Thank you, sir.
Any comments from the faculty today, Dr. Sumit, Dr. Adam, and Dr. Patnaik?
Thank you very much, Srijan, and I'm thankful to all IASO, as it's our parent body, giving me this opportunity to present a couple of videos. Thank you all the faculties, Professor Muhammad. It was really eye-opener, something to try robotically intragastric things. Thank you very much.
I thank the organizers and nice videos, Dr. Sumit. Dr. Adam, when Srijan came from US and saw your thing, from then we are trying to bank on your procedure, but we need to get a good case. And as the cancer center, still we are early to get some benign to catch hold of something and to try. That is why he was asking you regarding all those trocars and what all to go, gel ports and all. We have our own arrangements. So just waiting for a good case to come so that we too will have a case ready for you for presentation. Thank you. Nice to meet you all.
Thank you. Thank you.
Thank you, Sir.
Thank you so much, Dr. Shukla and Dr. Rao, and learn a lot, Dr. Patnaik and Dr. Shah. You could consider that, because I'm not a good radical gastric surgeon, as you are. I'm trying to kind of do this kind of like cheat, gastrectomy or mini gastrectomy. So, I've learned a lot from being here and when I was there, and the memories still stick with me. And Really appreciate the opportunity to talk to all of you. Happy to collaborate. If you have that case, let me know. We'll be there in a minute. So.
Yeah.
Right.
Thank you.
So that's all from us today. I think brief announcement, we'll have ISO masterclass on bone tumors on 15th September, following with an ISO Mastery of Surgery on 29th September, both Tuesdays, both 7 p.m. Indian Standard Time. With that, we would like to conclude the webinar from our end at Bastarkam. On behalf of the team here at Bastarkam, me, Dr. Ziba, and Dr. T.S. Rao, we would like to bid everyone a very good evening ahead in India, very good day to Dr. Adam and others who have joined us from the US. Thank you all for logging in. See you next time.
Thank you. Thank you very much.